right, everyone. I don't know if you can hear me, but I can shout. NFL is the most important biomarker in the MND ALS field. My name is David Taylor. I am Canadian, and I am sorry for that, as well as my funny accent. But we're going to find out. And you know what? I have opinions on this, but my opinion is the only one in this room that doesn't matter. The only opinions that matter are the debaters and all of you. So before we begin, we're going to take a poll to see how you believe, yes or no, the NFL is the most important biomarker in the MND ALS field. So get voting, and then we'll see where we're at the start. And then we'll call up our very special debaters. It's what? It's too close? Fuzzy. Okay. I was going for distorted. No, I'm not. I can't. All right, I think we may have some results. Okay, wow. Looks like our team who's in favor has a job to do, and that team exists of two individuals who were recently awarded the Healy Innovation Prize for neurofilament. One of them hailing from the United States of the Barrow Neurological Institute. He is also known as Biomarker Bob. The other one from UCL in the United Kingdom, whose name literally translates to bad thorn in parentheses in the side of his opponents during a debate. Please welcome to the stage Professor Robert Bowser and Professor Andrea Malaspina. It's sort of there. You're off to a bad start. Yeah, I don't know if you're winning them over yet. Please take your seats. I can try to sing it, but thunder. Okay, we're good. For those who are going to say, nah, neurofilament light is definitely not the most important biomarker in ALS MND. We have first representing Malaysia. She is also known as the Slaya from the University of Malaya. And her partner from Australia, right here at Flinders University, dialing it all the way up to 75, and I mean P75, everybody. We have Professor Nortina. All right. Rules. I have an opening 5 minutes. I will keep you very strictly to time. Don't take advantage of me because I'm Canadian. Okay? I will. And then the other team will have one presenter for 5 minutes. Then we will go back and there will be a 2-minute rebuttal with a 3-minute extra piece if you'd like, as well as the same on the other side. And then we will open it up for any thoughts from the audience. So beginning, tell us why neurofilament is the most important biomarker in ALS MND. Who's starting? If you would like, yes?
I'm not really a bad form in anyone's spec, but 5 minutes to state or reiterate the primacy of NFL is very easy because it's factual. Essentially, one preamble. So we heard from the keynote lecture today that biomarkers will model our understanding, given we are trying to understand also the reach of genetics. there are a number of factors that make NFL supremacy under commas, obviously, for the time being. The protein, neurofilament isoforms are essentially structural and functional component of the axon, and they have a compensatory role in a way they react to the stress axons are put under in a condition like ALS. The second aspect is analytical. So from 2015, there has been an exponential jump of the way we conceive assays for proteins, brain proteins in plasma, with neurofilament light chain opening a new era, not only for ALS, but for neurodegeneration in general. So for those who are not very familiar, I think very few of you, you have this linearity in the assay in plasma, which means that the more you dilute your sample, the more you keep a linear increase or decrease of your concentration. You have a very good correlation between CSF and plasma, which was not the case until very recently. And the protein is very stable. The assay are reproducible and valid in different conditions. The third aspect is undeniably the powerful effect in prognostication, in clinical stratification, which is what we heard today from Hama. So essentially, we need something that allows detection of clinical phenotype, prognosis, but also definition, possibly, of biological mechanism, which may relate to the release of neurofilaments. And another important aspect which comes out from the work we've done, mostly led by Mike Benatar, but essentially also pushed by our ability to develop the right assay, is the diagnostic element. Don't get me wrong, we need clever and wit and good neurologists with wit, without whom you wouldn't have a diagnosis. And the neurologist is sufficient for the most complex case in terms of clinical presentation, but early diagnosis, see this shift of neurofilaments that go up in a situation in which individuals go from a pre-symptomatic through a prodromal and then symptomatic stage. And in order to preempt any potential counterclaim from my opponents here, I would simply mention what we are left with if we take neurofilament light chain out of the question. Very little. So everything that addresses what we have enumerated today, metabolism, inflammation, is an early stage of development, understanding, and of analytical production. We will hear about things like P75, which is something I really put a lot of hope on, but still very early in a way that it could be used in a clinical setting and have the same impact in terms of understanding of the disease that neurofilament light chain has.
Okay. Right. So I'm from Malaysia, under-resourced country. Don't let that sway your votes. Anyway, thank you very much, Andrea. So you say facts. All I heard was that you were alluding to your fellow Brit, Amar Al-Chalabi's talk, to try and enhance the role of neurofilament light chains. Well, I don't disagree. It's helpful, but it's also helpful in a multitude of neurological conditions. So the problem here is that neurofilament light chains is not specific to MND, which is the problem here, because each individual is different. Patients that present to you with MND is different. You talk about, we require a neurologist with wit. I am that neurologist with wit. We do not have neurofilament light chains in Kuala Lumpur, in Malaysia. But, you know, I am still diagnosing my patients with MND. And basically, the idea here is that, you know, we're moving towards personalized medicine, treating each individual patient, not the same, but according to what each patient presents to you. So MND is heterogeneous. To say that one serum biomarker gives you the answer, I don't think so. Certainly, you can't use the light chains to diagnose. You need still the neurologist. And you need a neurologist, even better, who has neurophysiology, which I think Andrea did not realize that I was going to be the secret weapon to come up with the biomarker that I'm advocating here. And we heard about it. Today's session on biomarkers, there was very little about neurofilament light chains, but there was a lot about neurophysiology and also imaging. Both of those go hand in hand. So if you think about it, when the patient presents to you, even at an early stage, you can, with the Gold Coast criteria, of course, it's not a must to have neurophysiology, but when you cannot detect upper motor neuron or lower motor neuron involvement, this is where neurophysiology comes in handy, very useful, and also to chart disease progression. And I would argue that the advance that we've made, and we heard this today during the biomarker session, that helps, and that's what we need to be moving towards. So if you look at the field in great detail, and I'm in Australia where, you know, the birth of the cortical excitability studies, so there is a lot there that has not been explored and has been overlooked largely by the Europeans and maybe the Americans. Okay, I have to disclose that I did spend about 7 months with Matthew, so I may be swayed by the team. But I think that there is something there. And now we see that imaging is becoming much more important as well. So patients, MRI, we heard about MRI being a biomarker, and ultrasound, something that I do personally, that's become more and increasingly more and more helpful. And those are biomarkers that I think what you want to do is be able to utilize those to see whether there's any reversal or any dampening of excitability with any excess, any clinical trials. So those are my key arguments, and those can be specific with the right neurologist at hand. Thank you very much.
All right, so I get 20-minute rebuttal? 20 minutes. All right, so what can I say about what we just heard? I think we heard imaging, we heard electrophysiology. Electrophysiology can be useful for diagnosis. You're not going to follow that in a clinical trial. TMS, we tried, it failed in clinical trial formats, and it wasn't consistent across sites to follow and track. MRI, what are we looking at? Changes are small. During the course of disease progression, the patient will be unable to get into the machine. So you're going to end up not being able to put progressive patients lying flat in a machine due to respiratory problems. Both of those fail. Let's return to neurofilament. If you need neurofilament testing in Malaysia, I'll happily provide it to you. So there you're fixed. Neurofilament, as Andrea mentioned, it's been studied for a very long time. It's been validated on multiple platforms by labs around the world. No other biomarker in ALS has done that. That already places it at the top. Neurofilament's used in clinical trials. It's used as a covariate for baseline neurofilament levels are used as a covariate in most ongoing clinical trials. Regulatory agencies are looking at neurofilament to provide information on trials in ALS. In the US, accelerated approval of tofersen was provided because of reductions in neurofilament. That alone is the only biomarker in the world of ALS, MND, that has regulatory input in sort of a thumbs up. You can show changes in neurofilament, reductions over time, you might get your drug approved by multiple regulatory agencies across the world. There is no other biomarker that provides that. None. None of the biomarkers we're going to hear about or have heard about provides that information, both scientifically to the clinician and also to the regulatory agencies. We know neurofilament, even with different drugs of mechanisms of action, upcoming trials are pegging a number, a baseline level. You must be above a certain threshold. That's who we're going to include in our studies. Again, no other biomarker in the ALS realm has that type of information, has that input on both clinical trial design, clinical trial management, and input and decisions from regulatory agencies. So I think it's very clear. Neurofilament is currently the top dog as a biomarker in MND.
Bob, you're very persuasive. I'm going to come about this argument from a little bit of a different angle. I think that NFL, neurofilament light, is absolutely top notch, as you say, but it's only, as you say, for the person trial and for others. But there's many parts of the disease that actually NFL will not show. Like, for example, the trial where they looked at whether giving riluzole, which riluzole is a drug that people get prescribed, but actually NFL didn't go down because excitotoxicity is not, like, the neurofilaments are not related to excitotoxicity. What about other types of processes, like what happens with TDP-43? Like in the future, I'm talking about the future where we hope to see assays to look at cryptic TDP-43 or the peptides that are produced, lenpetraculi, which we heard about in Miami, this great assay where so that's actually related to what happens in MND. So we need, my thesis is we need biomarkers that are related to the disease process that we're targeting, the drug is targeting. We also need more than one biomarker. And I think that NFL, there's up and coming biomarkers that may be as good or better than NFL, and NFL is not specific to MND. Exactly what Tina said. It's not specific, so other diseases have it. So there may be a marker that comes along that's absolutely specific, like cryptic peptides for TDP-43 that's specific for MND, that'd be fantastic biomarkers. So that's what I think, and I'm hoping that in the future we will have that. And the other, I just want to leave you with one more point, is that we need more than one biomarker, not just NFL, combinations of biomarkers that are more specific to each individual's disease, exactly what Tina said. So thank you very much.
So now it's going to get a little dirtier, because I think Andrea would like to rebut this and get thinking out there if there's anything you have burning that you would like to ask either one of them to help formulate your opinions.
I have to say that I'm really disappointed, because had you been at high school and asked to write an essay about this question, you would have got a bad mark because you're out of topic. So the topic here is, what is the best tool we have at the moment to advance our fight against MND? It's like an army that has to fight a battle. They use the weapons, the best weapons they have in that specific moment. It's not about conceiving a future military expenditure for winning a war. We have something that gives you a neat stratification, understanding of disease trajectory. By the way, we were in Miami, and the result of our work is that neurofilament light chain essentially improves prognostic models, okay, already existing that we use in clinical trial. It does give you a clear signal of disease initiation, obviously in individuals who are already at risk, coinciding with what we describe as minor motor impairment or minor behavior impairment. And it does give you a strong indication of a pharmacodynamic response. I'm not advocating the absolute surrogacy of any tool. So things have to be complemented and multimodal, like a bit what the MS neurologists had done 15 years ago. We are not there because the disease is different, but what we have is the best tool that is going to make an advance in the fight of MND.
Do you have any rebuttal?
Yeah, thank you very much for that. No, I mean, I agree to a certain extent. That's all we have now. So the idea is that there is a lot of things out there that's not being explored, that it really exists. And it's not explored because everyone's jumped on the neurofilament light chain bandwagon. And I think that's just a little short-sighted perhaps, because it is not specific to MND. It hits a ceiling, am I not right? That once the patient is, I mean, I'm now talking, you're obviously the expert, so this is a little bit unfair here. I don't even have access to neurofilament light chains. So it's
That everybody's jumped into the bandwagon on neurofilaments is right.
they are, aren't they? Yes. And I just think that, you know, if we're moving towards personalized medicine, which is what we're moving, you know, we should be doing, because patients see us, each individual is very different. They present to you with different sites of onset, different disease progression, different risk variants, different genetic mutations. So we ought to be focusing on where the problem is in each patient. And I do feel that, okay, I take your point about MRI. Admittedly, also don't use MRI I'm just kind of like saying that it's out there. But neurophysiology, I think, is something that is an extension of the neurologist seeing the patient to actually make the diagnosis and identify where the disease is and where the disease may not be so apparent clinically, but subclinically. So these are things that you can detect when you do careful electrophysiology. So that's my rebuttal.
So, okay. I think I saw Lucy's hand first, Jeff. Who? We have a roaming mic? Do you want me to do it? Okay.
So firstly, I don't think we can underestimate the impact that NFL has made. And obviously the team were well deserving. And I think they've set the stage to really standardize biomarkers and to make sure that if we're using it in context, that we have a standardized assay. So I think there's no doubt that neurofilaments have made an incredible impact and was the first biomarker for ALS to have a drug approved like tofersen. I think we've got much more to do now, though, because as a field, it's very easy, and I'll talk more about it tomorrow when we think of clinical trials and industry. Everyone is now hoping that their drug will change neurofilaments to the extent that tofersen did. And I think that might not be the case because, as you nicely pointed out, Mary Louise, it depends on if it's an inflammatory agent, actually your neurofilaments might go up because of the microglial, change and other confounding factors. So I think we have to be careful about that. And I think an ideal world will be more soluble biomarkers. I don't believe imaging is going to be useful for clinical trials. And so I also peg hopes on TDP-43 moving forward. But I think for the genetic cases like C9, in particular SOD1, as an early indicator, so for early treatment, it's great. So I think I'm sitting on the fence because I think there is, in context of use, huge value, but we have to be careful because we now need to know how to use it effectively.
Yeah,
So I'll add to that, both teams, team 1 and team 2. I'm going to go a little heavily on team 1, but one of the issues here is that the word biomarker, you're all mixing it together. Diagnostic biomarkers are different than drug response biomarkers. This is a fantastic marker for when cells are injured or dying. It's not about drug efficacy. The clinical readout is drug efficacy. If you're preventing cells from dying, you're going to change the neurofilament. But TP43, which many of us think is fantastic biomarker, it's not about cell death. It's a druggable target. So the categorization is very important. I know you guys know, all of you know this. I know you especially know that. EMG, forget it. I'm sorry, EMG is not going to be useful for physiology as a readout. It's great for diagnosis, and you know very well, you don't make a diagnosis by EMG alone. It's a clinical diagnosis. So I agree. I think it's an incredibly important, you've outlined it really well, the two of you. What's missing, and you hinted at it, Bob, the idea that suddenly all the companies, and this may not reflect this audience, are jumping on it. And there are going to be companies that said, look, I got a statistically significant lowering by 5%. That's complete bullshit. Oh my God. We don't yet know how much change in neurofilament is necessary to correlate clinically. We've got great
Well, we sort of
results.
do tofersen. So if you can
No, we
reduce
know
it
one.
40 to 50%.
No, I agree. We know one, but what
I don't
about-
think any other drug will do
Exactly,
that.
exactly. So that's lacking, but companies are already thinking it's meaningful. It's not. It's any of us who do science know that N of 1 is important. FUS, by the way, is the other one. FUS is also hitting the same target. So I agree, but I just have to think, sorry, I'm repeating myself, that this is really about a death or an injury biomarker. It's not a I don't even consider pharmacodynamic. It's not a drug response to a drug target. But that's.
Well, I might
yeah.
disagree with you there. So pharmacodynamic can be protecting of cells.
Okay, like.
And so if it's
This
a
is gonna be
neuronal
big,
injury
yeah.
marker, well, that's another thing. But I just want to add, there was a discussion or mention of cryptic exons. I think that can be a great biomarker for TDP function or loss of TDP function. We're years away from having assays that are reliable and predictable. The ones that have been published are actually not very good. If you look at the overlap between what's really there, how much cryptic exon that they're seeing, it's in a very small subset of the patients, and even some of the controls have some. So it's not very good yet. There's going to be many. And I would predict, and I love, we heard some blood transcriptomics data, and I wanted to talk to Amar about his. I would predict that if you take this idea of cryptic exons and move it into the periphery, what we're detecting currently in the brain, in the CNS, has been published. I don't think any of them will work in the periphery. I think it'll be a whole new set of cryptic exons that are from blood-based cells that are really generating a signal in the periphery. And so I think everything that we've found to date in the CNS won't translate to the periphery. We're going to have to look at all this data that's being generated in the peripheral transcriptomics and find those cryptic exons. And those will be the ones that will be valuable because you can use it in blood. How it correlates to the CNS disease, whole nother issue and question, because it would be a different marker. But again, we're years away before having that. And so I think still at the moment, neurofilament's the top dog.
My turn.
Dr. Genji, you have 1 minute.
Oh, no.
I know.
They used up my minute. Okay. So I apologize. I'm also Canadian. Nice to be here. Neurofilament is an important biomarker. That's it. It's not the most important biomarker. There are many other biomarkers. We are going to see, the one thing I agree with my noted colleagues, who I think I'm already debating on your behalf, Nortina, is it is of value because it has aided in the interest in drug development in ALS, because we finally have something to go on. It has been a nightmare because now every funding organization puts 100% of the emphasis on NFL. We have to, and everyone, a number of people here are working on it, develop these target engagement biomarkers, because the decision as to whether a drug is useful in ALS needs to happen way earlier than we are doing it with our ALS FRSR and survival.
I get my whole minute, maybe a minute and a half, Andreas, hang in. But it's not the most important. Change your clock. I'm not done yet. And I take exception to one statement I've heard twice, and I strongly take exception to it because I appreciate my hosts in Australia, and hyperexcitability has moved forward really because of the ALS community here. We have now had one published study that shows that the newer innovations in hyperexcitability, EFIS, is really fine tuning. We're not doing what was done 25 years ago. We're talking about very new techniques that can be looked at as a surrogate marker. And so for those of you who are doing hyperexcitability, I'm in. And I think that it's nice to have neurofilament, but we must be very, very cautious in making it the be all and end all. And that's the Canadian in me.
Can I just make a disclosure? No, for me. I wouldn't do a disclosure for you. No, we had to decide about this debate. So I would have felt equally comfortable to be on the other side. So, but this doesn't diminish the importance of that statement. I mean, with all the vagueness that the importance entails, this is a matter of fact. So I think we have changed your perception, hopefully. But what I wanted to say is that I think I've been unwillingly placed into a contest where I seem to propose also the pharmacodynamic importance of an NFL, which I think is not at all known. So I think neurofilaments are released for a number of reasons. And what you have in your biological fluid is the results of your release or production and your clearance. And medication act on this in many ways. One question I have, if to all of you, if we had not seen—
You're not allowed to answer, by the way. Yeah, it's a question.
Yeah, no,
We don't have time for
sorry,
answers.
The question is, if we had not seen any a separation of the Kaplan-Meier curves in tofersen after 6 months, in initial separation, what would have been your interpretation of neurofilaments drop? Even after a year, let's say. So what I mean is that the clinical trial should have carried on for another 6 months, and we would have seen clearly the clinical effect. And you know, most likely the drop in neurofilaments is indicative of treatment response, but there are a number of other things that can act, and also the drastic reduction in analyze that is supposed to have a 3 to 6 months half-life. After a month is somehow something that has to make people think. But tofersen works. Obviously, it's the first treatment we have that really works.
All right, great. Well, I'm going to quickly summarize. We have who's in favor of it here. Neurofilament is a great tool that we can use in many different ways, but we have to be cautious about what we know. We've heard from the audience about misuse of this until we know more. And one thing that we didn't hear, I think, was also that there are a number of people who are currently fast progressors with SOD1 variants who are being treated very early because of neurofilament. And if they are the first people who have very fast progressing histories to be cured of the disease, I think that makes it very important. From the other side, there are a lot of different things, and we've seen them all. This is not a specific biomarker if you want to use it for diagnostic purposes. So maybe it's just a tool for certain things, but also there are many other avenues we need to continue to explore. And if TDP43, for example, is incredibly important target, then cryptic exons might be one that's great, as well as all the other things we've heard about this morning. So without further ado, have we done the votes while I've been talking? We're ready? Okay. Go for the votes, everyone. The QR code. Where's the QR code? We don't have the QR code. All right, it's happening over there. Okay, there we go.
What's that? We're not going to vote.
No, we know your votes.
Right.
Right again. Yes.
Oh, wow. I think we have a winner. Oh, it's not done. I didn't know it was dynamic. Someone needs to tell me that. This is like an American election. So I think what we've learned from this is that they brought more people to the side of yes, but there's still a lot to know and a lot to learn, and that's why we have meetings like this. So thank everyone for their wonderful discussion. And I think there's some students awaiting their presentations now.